Thank you. Hi, everyone. I think we can get started now. So, hello. Welcome to this month's Journal Club. To start with introductions, I'm Ian, one of the program coordinators for the Johns Hopkins Global Surgery Initiative. I'd like to welcome our guest speaker for this evening, Dr. Chao Long Azad. Chao is actually a part of the Johns Hopkins Global Surgery Initiative, and she's actively involved. We're very excited to have her join us tonight to talk about building global plastic surgery capacity. Chao is currently a plastic and reconstructive surgery resident at Hopkins. She obtained her bachelor's degree from Princeton, earned her MD at Stanford, and completed her MPH at Hopkins. She is interested in enhancing access to high-quality, patient-centered, and cost-effective surgical care, both domestically and internationally. She's had field experience in China, Cameroon, Nepal, Ghana, and Thailand, and she brings a wealth of diverse perspectives. Clinically, she hopes to specialize in hand and microsurgery. So starting off our session today, Chao will be sharing more about her background and global surgery. And then afterwards, we'll transition into our two student presentations of the articles and some discussion. So I'll now turn it over to Chao.
Great, awesome. Thank you so much for that introduction, Ian, and thank you so much for having me at this journal club. I still remember a few years ago when we started these journal clubs, I was in Ian's shoes playing the host and the MC, so it's an honor for me to be returning as the person leading the journal club. So yeah, I guess before I dive in, Ian, do you have a sense of kind of who is in the audience, whether it's mostly like medical students or trainees, or do we have attendings? And do you have a sense of whether folks are from the US or from internationally? Just curious kind of who our audience is so that I can tailor my comments appropriately tonight.
I think it's a mix of international and domestic, mainly medical students, but also MPH students. And we share a link broadly, so it's whoever gets a hold of it. Yeah.
Okay, great. Okay, that's super helpful. Then in that case, I'll kind of start by sharing just some comments maybe about kind of how I got to where I am and my path in global health and global surgery, and how I became interested in global plastic surgery specifically, because I think when I was in the shoes of being as a med student or as a MPH student, I think a lot of what I was trying to figure out is, where I really wanted my career to go. And I knew I had interest in global health, but exactly what I wanted to do in global health was a much harder thing for me to figure out, because there are just so many directions that one could go in. So I'll just share a little bit about my background, a little more detail about my background. And I wanted to share that, in hopes that if there's anything that I say that resonates with you, or if there's anything that I say that you have follow-up questions about, I would encourage anybody to either, just unmute and ask them, or write your comment in the chat box. And I'm sure Ian can monitor the chat box for any questions that come up. I think that when I was in your shoes, the most helpful thing was really chatting with individuals who I saw and who I saw maybe had careers that I was potentially interested in, and really hearing about what their career was and what it meant to them and where they wanted to go, and trying to figure out if that's something that I wanted to do. And I think that those conversations really helped me navigate kind of my own career. And obviously I'm still training myself. So I'm very much in the kind of the early stages of my career and still trying to figure out some of the details of that as well. So I have been interested in global health for a long time. When I was in high school, I went on kind of my first trip abroad, and I think that that's how a lot of us get started in this type of work. You go on one trip, you're kind of your eyes are kind of opened kind of to the just massive need abroad. And when I first started, I actually just worked in an orphanage, and I did something that wasn't even medically related. But I eventually went to college. And when I was in college, that was when I was first introduced to the world of medical anthropology. And medical anthropology is kind of how I actually got my introduction into medicine. What I loved about medical anthropology was really realizing that health is affected not only by kind of physiologic states or diseases, but that there are social, political, cultural, etc., so many other kind of layers that all contribute to that could potentially contribute to health. So what after, when I was in college, I ended up doing a few trips. I studied abroad in Cape Town. I studied medical anthropology there. And I decided ultimately that I did love practicing, where I loved delivering clinical care. And I delivered clinical care primarily as an EMT. And because I really like the clinical kind of patient interaction component, that motivated me to go to medical school. Once I was in medical school, I was really torn because I was drawn to plastic surgery at a pretty early stage in medical school. But it was really hard for me to actually see the intersection between plastic surgery and my interest in global health. I think that if I wanted to do global health, a lot of my mentors were encouraging me to pursue something like infectious disease or just go down the medicine path or pediatric surgery, for example. A lot of, my mentors kind of felt like if you really wanted to do global health, they felt like you could have bigger impact in those spaces. But ultimately, I think that what I decided for myself in medical school was that you can, even if you have interests in disparate places, if you're really passionate about them, you can kind of charter a course for yourself. And I think in retrospect, now I don't even know why I thought that there wasn't an intersection between global health and plastic surgery, because now that I've been, quote, doing global plastic surgery for maybe the past decade or so, I think that there is so much need for global plastic surgery. And I think that it's a field that could benefit from so many more people really getting on board. And I can kind of speak to a little bit more of why I think that is as well. So when I was at Stanford, which is where I was a medical student, I had really great mentors who were actually general surgeons. And even though they were general surgeons, I think that that was one lesson that I learned early on, was that good mentorship is so key to kind of your success in your career. And I think that you don't necessarily need to find the mentor who does exactly what you want to do, because maybe exactly what you want to do is something that nobody else has really done before, not many other people are doing. But I do think that just finding mentors who are good mentors, who are really dedicated to your success and kind of nurturing your growth in your career is really important. And I attribute a lot of kind of the path that I've taken to the early, really strong mentorship that I had. I spent some time during medical school really working on actually developing trauma registries, and that work was done in Cameroon. So again, that was done with general surgery mentors. And I also did a lot of work in Nepal trying to build a skin bank. And one of the articles tonight is about that. So we can talk more about that if that's a topic that's interesting to any of you guys. We also don't have to spend a lot of time talking about it also, because it's very niche. So again, we can definitely take this journal club in whatever direction is most helpful to the group or most interesting to the group. After medical school, I ultimately matched to Johns Hopkins for residency, and now I am a plastic surgery resident here. Once I got here, I really realized that if I wanted to have a serious career in building global plastic surgery capacity, which is something that I want to dedicate my career to, but I really kind of needed some more of the chops and also kind of the connections and kind of the more foundational understandings of things. So that's why I decided to pursue an NPH. I do think that there is so much, to be learned in NPH. I think even when I was considering whether to get an NPH or not, I had gotten some conflicting advice about whether it really was useful or not. And, obviously there's that's a whole entire other conversation, but I personally am of the belief that that what you learn in medical school and is not necessarily does not include all of the skills that one needs to have a successful career in global health and in global surgery. And I would say in residency, I think my most of my work has been building a partnership with a plastic surgery fellowship in Uganda. So Uganda, there's only one plastic surgery, they call it a fellowship, but it's really a residency in Uganda. And it's kind of not only the only residency in Uganda, but it's the only plastic surgery residency kind of in that entire region. So we've built a partnership with them, and in the past few years we've done a few trips primarily focused on plastic surgery education. So if that is of interest to folks, we can also talk about kind of what that work has involved. And that is only one of many models for plastic surgery training and education. So we can talk about that and other potential models and, pluses and minuses of the various options. So I guess, that brings us to today. And I think, if anybody is interested in kind of like why global plastic surgery, why is it important and why do we care about it? Hopefully if you're on this call, this isn't a point that I really need to belabor, but I do think that there are two specific points that I think are that make me think that global plastic surgery is a really interesting and important field to be in. The first is that I think plastic surgery is a great amplifier for other surgical subspecialties. You can call it an amplifier or maybe a surgical enabler, et cetera. And what I mean by that is that plastic surgeons really work with other surgical subspecialties to kind of optimize what they can do. And not only optimize what they can do, but kind of treat the severity of patients and help those patients have better outcomes. And let me just give you a few examples to help illustrate that. So for orthopedics and limb salvage, if you have terrible limb extremity trauma, which is something that is a huge issue in LMICs. Yes, the orthopedic surgeons can stabilize the bones, but oftentimes there is a soft tissue defect and there won't necessarily be a good outcome unless the bone is covered with some sort of, if there's a soft tissue reconstructive procedure that's done to help cover the bone or the underlying hardware, or maybe a nerve is out and the patient ultimately won't actually recover function of that limb unless plastic surgery is there to help reconstruct the nerve. So, even in after limb trauma, a huge issue is osteomyelitis and septic joints, et cetera. And a lot of those end up going on to amputation. But I think that plastic surgeons have a role in being a quote surgical enabler, something that I've been calling it. To allow orthopedic surgeons and to do their jobs better. And another example, for example, is vascular surgery. So after a patient who's had maybe multiple procedures, maybe there's exposed vascular grafts or bypasses, and in those cases they could benefit from soft tissue coverage as well. Or for neurosurgery, if there's a large cranial defect, we can perform a cranioplasty. We can help them with that. Or for general surgery, if there are patients that have large ventral hernias with loss of domain in their abdomen, they may need abdominal wall reconstruction. So, my point really is that plastic surgery can seem like a nebulous field to some, but I think that it has a really unique role in global surgery because the presence of plastic surgery, I think, can really amplify and multiply the effect of all the other surgical subspecialties. And I think that the second reason that I really enjoy global plastic surgery and think that it's important to build plastic surgery capacity at the global level and in LMICs is because I think that as broadly as healthcare workers interested in advancing global health, I personally think that the mandate is not only to save lives, which obviously is important, but I think it's necessary but not sufficient. And I guess what I mean by that is that I think that our mandate is also to ensure that we're saving lives that are worth living. And plastic surgery, I think, is a specialty that is perfectly suited to do that because of its emphasis on restoring form and function and really from head to toe. And I think that, you know, it's a personal opinion of mine that, you know, saving a life, again, no one is arguing that that's not important, but I think that just as important is really asking, you know, what is the quality of life that we're saving? And is the quality, you know, are we ensuring the quality of life that we're saving? And I think that plastic surgeons in that way also have a really unique role to play in global health and in global surgery, because that's kind of, you know, that's what we do. And I guess one final comment is, you know, I think I just don't want this comment to get lost. So, and that is that I think it's very easy to want to work in silos. You know, obviously the talk of this, or the title of this journal club is global plastic surgery, building global plastic surgery capacity. But I really don't want anyone to think that I'm here with a banner saying rah plastic surgery at the expense of any other surgical subspecialties. I really think it's not a finite pie. And I think that the point is not saying plastic surgery is more important than anything else, or trying to convince you that plastic surgery, you know, is better or more important. But I think that my shtick is really that plastic surgery should be integrated into the broader surgical efforts that collectively allow us to take better care of our patients. And because I think of, you know, these unique ways that plastic surgery can contribute to the collective efforts, I really think that plastic surgery should be kind of part of these broader efforts. Okay, I guess I could really continue talking at length, so I'm just gonna stop myself there. And I don't know, Ian, do you want to do one of the articles or see if I don't know if there are any questions or follow-up questions to that, but.
Yeah, thank you, Chao, for providing us with a background and a glimpse of your experiences. And I really love how you hit home the importance of having a good mentor, and that it's okay to adopt a less conventional approach to pursuing your interests. And I really appreciate your openness in explaining the role of global plastic surgery as a surgical enabler, and for providing examples that most of us probably haven't previously considered. Um, I guess, are there any questions or thoughts from the group for Chao at this point? Go ahead, Sana.
Hi, thank you so much for this wonderful introduction and actually broadening our vision to the global health from the perspective of plastic surgery, which, to be honest, I didn't really think of before. I'm currently doing Masters of Public Health, and I see global health from that perspective of crucial importance, that building plastic surgery capacity in different countries is very important. So my question is, when did you take the building steps of actually increasing the capacity in different countries? Was it during MPH? Is it during residency? When was the exact time that you start? As I understand, you had a couple of mentors from the general surgery, but my point is, when did you start and what was the first step? So that if someone wants to take the same approach into building capacity in different countries, maybe in plastic, maybe others, that they can actually replicate that.
Yeah, such a great question. And thank you for kind of refocusing us on building capacity, because that really is what I think is what we need to be talking about. So I think that for anyone interested in building global plastic surgery capacity, I think that you first have to think about in what way you want to build capacity, because I think that, there are many domains in which you can do so. And I think that those aren't necessarily dissimilar to kind of what might exist for general surgery, but I do think that maybe there are a few specific plastic surgery comments. So I'll briefly cover some of those domains, but for myself, I guess for me, I would say maybe my first attempt to build general surgery capacity was building a trauma registry. Because that registry still exists, and it was really an attempt to collect a lot of trauma data in order to guide decision making about how to take care of trauma patients. But specifically in plastic surgery, I would say it was my work in building a skin bank in Nepal. So when I was at Stanford as a medical student, I took a class actually called the Design for Extreme Affordability. And in that class, I worked with a NGO called Research, and kind of our mandate was how to improve the disparities in burn mortality between Nepal and high income countries. So our solution was building a skin bank, and I certainly consider that as surgical capacity. Not first of all, I'm really proud that it is still in existence today, almost a decade later, and also because it really is giving the local community and the local hospital kind of the capacity now that they have cadaveric allograft skin to take care of their own burn patients. So to go back to kind of, thinking about how you want to build, if, you were, thinking about how you wanted to start down this path, I think that there are a few broad buckets of how to build capacity. I think the first is education and training. So training plastic surgeons. Or at least training surgeons or training healthcare providers in general to do plastic surgery procedures. I think that if you're interested in education and training, I think that there are a few models that you can think about. The first is obviously, replicating what we have here. I would say that is probably the least feasible or realistic, or at least most challenging thing to replicate. Just, my surgery program is 7 years long, and the sheer amount of resources that one needs to establish a 7 or 6 year long surgery training program in an LMIC is a lot. So that would be very challenging. Obviously, if you can accomplish that, that would be phenomenal, and that's kind of the dream. But a more feasible model, I think, is thinking about plastic surgery fellowships that can supplement a general surgeon's trainings. So in Africa, or the COSEXA region, they do have a formal plastic surgery fellowship, but you can also consider supplementing kind of informally through piecemeal educational opportunities. So the NGO that I work with, they support general surgeons to do rotations, basically in plastic surgery hubs in countries that aren't where they normally work, so that they can get those experiences and training opportunities. And kind of in that same model, you can build, help develop plastic surgery curriculum or curricula that are intended for LMICs that really kind of include a core set of plastic surgery competencies. And then finally, I think that the last model that I can think of that I've seen is LMIC trainings finding opportunities in high income countries. The risk of that is brain drain and them staying in high income countries and not going back to their countries to actually deliver surgical care. And also there are limited surgical opportunities available in high income countries, of course. So it's a tenable solution, not a tenable solution, in my opinion, and more of a stopgap solution. So I think that that's education. I think that if you're interested in building capacity, you can think about any of those models. You can find either mentors or NGOs or a number of other organizations who maybe are tackling the problem and kind of get involved in that way. Another way to build surgical capacity is through building surgical systems. So thinking about how to build local surgical care delivery systems. And I think that, the skin bank, for example, is one way of doing that, but there are many, many ways of doing that. Next is research, which I'm sure many of you know about. There's a huge need to collect and generate data. And I think that that's maybe obvious, but I think that it's especially important in global surgery because data is needed for advocacy. And I think that I actually think that that's an area that plastic surgery is particularly behind in relative to other surgical specialties. So, foundational data points like the burden of disease that's amenable to plastic surgery intervention or the available plastic surgeons that exist worldwide. All that is information that we do not have, and no one has quantified these very basic metrics. So I think that in order for us to advocate, we need data and we need evidence. So if you're a researcher or if you're getting your MPH and kind of, getting your research, building up your research chops, I think that that's a great way that you can think about how to contribute to plastic surgery capacity. And then I guess the final big bucket that I can think of is advocacy and at multiple levels. So at the local government level, at the National Ministry of Health level, on the broader global health stage. And I think that when I was, maybe a decade ago, I was not really sure what that meant. And when I think about advocacy, I one specific example always comes to mind, and that is one of the plastic surgery fellows. He graduated from the residency in Uganda, and he couldn't find a job. Even though in Uganda, there are 3 plastic surgeons, to my knowledge, in an entire country with a population of 45 million people, and a plastic surgery resident who just graduated, fully trained, couldn't find a job. And the reason he couldn't find a job is because in his country, in Uganda, positions are created for the entire country for physicians, and the country only allocated 3 postings to plastic surgeons. So there simply wasn't a job for him to take because the Ministry of Health wouldn't allocate resources to create another job for another plastic surgeon, even though there clearly is a deficit of plastic surgeons in the country. So to make a living, he was essentially forced to start a private practice clinic where he either treats cash paying, relatively wealthy patients or does cosmetic procedures. And I don't blame him. Obviously, he needs to make a living, but I think that that's at least for me, a really poignant example of the importance of advocacy. Because even if we do all of these things, even if we train surgeons, unless we advocate, for example, to the Ministry of Health about the importance of plastic surgeons and why we need to the importance of what we do. That it's not going to be enough. And I think that also ties into kind of getting local buy-in and really strengthening local partnerships in kind of anything you do. I think that that's really foundational in the bedrock of all global surgery and global health, honestly. So I hope that answered your question.
That was a wonderful response. I actually took note out of that. You have pointed out 7 things, and I got a point of advocacy, research, and also the drawback of getting the LMIC and the people living in low and middle income countries into high income countries and their risk of not going back. I can actually, relate to that. This is also an issue in Pakistan also. I have a follow-up question for the NGO that you said, like building the local surgical delivery system, like you were able to do for the skin bank. And the current NGO you might be working with, how to find NGOs? Is it affiliated with Hopkins that it's easy to reach out to, or was it your own interest in searching?
So the specifically the one that I was talking about is called Resurge, RESURGE. So you're more than welcome to Google them, and they work with a lot of students, and you can certainly reach out to them to get to figure out how to get involved. So if you're specifically interested in plastic surgery, I would say that they're a great organization to get in touch with and see if you can work with them. Their mandate is to build reconstructive surgical capacity worldwide. And I think it's really fantastic because, maybe, I don't know, 5 or 7 years ago, maybe a decade ago, I don't know exactly when, but they used to be primarily mission focused. But now they've really changed their model to one such that they still do deliver surgical care, but they also have a lot of training and capacity building built into their model. So if you're interested in building global plastic surgery capacity, they're actually the only NGO that I'm aware of that does that. Obviously there are others like Operation Smile, Smile Train, et cetera, that do that for very niche portions of, or a segment of plastic surgery, but Research is the only NGO that I'm aware of that does that for plastic surgery broadly.
Thank you. That's very helpful. Thank you.
Yeah.
And if someone, I think there might be some audience who are interested into other fields of surgery, and I'm sure that might be some baby steps being taken for the global health good. So, how exactly is it possible to find different NGOs working for different surgical specialties? Should we randomly Google?
Yeah. I actually think Twitter is an excellent resource. The global surgery community is very active on Twitter, and I think Googling obviously is the first best what you should always do first, but I think Twitter is a great resource. I would also say identify individuals who are doing whatever you're interested in, and then just ask them, because if they're doing what you're interested in, I'm sure they'll have kind of leads for you for which organizations are doing that.
Yeah, I think that answer is helpful for multiple people's interest. Thank you so much.
Of course.
Ciao. We can take more questions at the end, and we'll jump into the readings next. So we have 2 trainees who have kindly offered to summarize the articles that were chosen by Chao for today's discussion. So we have Shaan, who will be presenting the first article titled, What is the Role of Plastic Surgery in Global Health? So feel free to share your screen as you talk us through it.
Yeah, sounds good. Just give me one moment. Great. Can everyone see my screen?
Yeah.
Awesome. Okay, great. Yeah, so this article is a really nice primer into the importance of plastic surgery in the context of global health and some of the challenges encountered in the field. There's some points that I'm happy to recapitulate here. Firstly, this article starts with some key statistics about the contribution of surgical conditions to global disease burden. And there's several important ones. 66% of the contribution of surgical diseases to DALYs, so basically global morbidity and mortality, is comprised by plastic surgery associated conditions. And it's also important to note, as we've already mentioned, that these plastic surgery conditions and the disparities within those are especially accentuated within LMICs. And we've talked about several factors. One factor we've already mentioned, especially, is the shortage of plastic surgeons in LMICs. And this article also discusses some initiatives to address that we can talk about as well. But then the article really launches into a discussion of several really important use cases that, again, highlight the importance of plastic surgery, especially global initiatives in plastic surgery. First, I can start with burns. I think there's several insights that can be gleaned from here. Again, like many plastic surgery associated conditions, burns are overrepresented in LMICs, but especially something that we can glean from here is the diverse sources of these conditions. As we mentioned before, there are cultural factors that can lead to plastic surgery treatable conditions, such as practices surrounding large open flames for cooking, the lack of robust safety infrastructures that might lead to live wires being exposed, so social factors, and then broader geopolitical factors also from wars and conflicts that might also lead to burns. So one major insight from there would be that to really wage a global plastic surgery initiative initiative, you have to be conscientious of the local as well as the cultural context. And one thing that is not mentioned as much in this article, it's talked about more in length in the other one, the skin banks, but skin grafting, a lot of these other interventions, some of these interventions that are in the plastic surgery repertoire are met by scrutiny from different religious groups, because we can talk about that when we talk about the other article. And moving on to the next use case with CLP, just like as we saw with the diversity of the sources of these conditions, there's also a diversity in the consequences that we see. With CLP, as you would imagine, cleft lip and palate, you can see that there's this detrimental impact on very many core indicators of health, like this increased risk of malnutrition, infection, speech and feeding problems, many critical issues. But beyond that, as we see with many of these plastic surgery patients, their needs really tend to transcend beyond the biological and physiological. These children with CLP face vast social stigmas. So that leads to this deterioration of their financial and their mental well-being, loss of employment opportunities, violence and ostracism from their society. So some insights we can glean from there, from this use case, is that an ideal plastic surgery initiative globally should be trauma-informed, firstly. Additionally, it should also ideally incorporate some aspect of community education, patient education, to raise awareness about how CLP, for example, manifests. And precisely this article mentions that the lack of knowledge is another contribution to the disparities found in LMICs. And there's some staggering statistics I just wanted to point out. 4 million untreated CLP patients worldwide who, again, have these variegated medical and non-medical needs that need to be met. Going back to physician shortages, some more staggering statistics. In China and India, less than 1/10 of the plastic surgeons per million people as compared to North America. Some countries in sub-Saharan Africa have less, and sometimes none at all. And just compounding this idea of problems with plastic surgery capacity and access, there's also this question of allocation of resources, especially people as resources. So this is kind of analogous to brain drain, maybe like a local version of brain drain. But we see here that there are some individuals who have the specialized training, perhaps in LMICs, who might be in urban areas, who are going for the more lucrative procedures, using the specialty skills for cosmetic interventions. And the point here is that there are so many people in these rural regions whose needs are going unmet, whose voices are being silenced. So ideally, again, a plastic surgery initiative through advocacy and other means should act as a soundboard for these patients. Okay, and moving forward, we've talked about some brilliant initiatives that have been waged by plastic surgeons globally, research, Operation Smile, Smile Train, and we also talked a little bit about this in terms of this very seminal debate in global health surrounding how best to really wage a global plastic surgery initiative. And there's two paradigms. I'm not trying to advocate for one or the other. They both have their relative merits and disadvantages. Mission trips, generally, this is international physicians going in and taking the charge in LMICs. And the advantages there would be, again, focused, targeted interventions, addressing emergent needs, especially when you have that tremendous backlog of 4 million CLP patients. That's especially important to consider. But some concerns, for example, might be, well, this is true for both models, but financial barriers. There's such intricate partnerships that are needed to make this happen, that'll inform how successful this initiative is. Continuity of care. What happens when the medical mission trip is inevitably over? How do we make sure that the host country is not necessarily dependent? How do we make a sustainable solution? That's important. As I mentioned before, being sensitive to cultural context when contriving these global health solutions is important. And I would also add that implicit in that is also acknowledging the histories of colonialism in these nations, which is especially includes global health initiatives in the past, like in the 20th century, for example. So being conscientious of that is important as well, especially if you're an HIC researcher going into an LMIC country. And then there's a care center model, as we talked about before as well, where here the idea is more to shore up local surgical capacity, to empower local experts and train them to conduct more complex plastic surgery procedures, but also to enable training for other procedures as well. And again, this is remarked as a more sustainable solution. It's better able to wage longitudinal solutions in terms of integrating various modalities of care, physiotherapy, plastic surgery, and so on. And it's not just an investment in the healthcare system. At least this article posits that this is an investment in the local microeconomy. I would also say this is also an investment in the people, right? It's an investment in these individuals who are especially adjacent to those, for example, the CLP patients whose needs are being unmet, whose voices are being silenced as well. And then one other just small nugget that I'd like to add in here, as I was talking about patient and community education before, that post-op education as well in terms of preventing infectious diseases, which are especially prominent in LMICs. It's also very important. So yeah, so all in all, this article is really a nice outline of some of the core tenets that we can use to drive and inform initiatives, such as the one that I guess we'll talk about in the second article now as well.
Thank you, Shaan, for providing an excellent summary for us. We'll have Skylar present the second article, and then we'll open the floor for any thoughts, comments, and questions. And also, Skylar, feel free to share your screen.
Yeah, sure. Oh, me. Sorry. Actually, I haven't done much of this. So. Oh, I guess I can. Sorry, I guess I have to change a preference or something. It's like.
It's okay to just talk us through it as well if you can't figure out the share screen.
Okay, yeah, I could also do that. Yeah, I can just talk it. So yeah, this was the second article, and it was focused on the creation of Nepal's first skin bank, as was previously mentioned. And really, some of the introduction is that burn injuries are the fourth most common cause of trauma globally, which I found pretty, it's a large number of injuries. It had, it says 11 million injuries with 300,000 deaths. And really, this is disproportionately affecting low and middle income countries. And in particular, this article focused on Nepal, where there's about 55,000 injuries annually. And so just to go over a little bit of the vocabulary before going into the rest of the article, total body surface area, or TBSA, is just a measure of the surface area of the burns. And then there's also a term called LA50, which is the total body surface area lethal to 50% of patients. And the article points out that in the US, the LA50 is about 70 to 80% TBSA, or the surface area. And in Nepal, it's actually 25%. And they also noted that the TBSA of greater than 40% leads to 100% mortality, which they made an interesting comparison that's comparable to World War II and pre-antibiotics in the US. And really, Nepal does have a lot of capabilities, but there's a lack of some resources as well that prevent, truly doing everything possible. So then the article goes into some methods of establishing the skin bank. There's a partnership locally and globally. So Research was already mentioned as an NGO. There's also a local hospital, a 75-bed hospital with a 42-bed tertiary burn referral center in sort of an urban area of Nepal. There is also American Nepal Medical Foundation, and then Stanford University. And really, the project had a few different goals. Really, one was to develop the tools and infrastructure. Second was developing quality assurance system, and then the third was really getting into patient education in the local area. Okay, so for the first method of developing physical infrastructure, really the goal was to identify and acquire materials and equipment for producing the cadaveric skin. And so some of the unique considerations for Nepal include the unreliable availability of electricity, and that really affects everything from storage of the skin samples to record systems. And so one of their solutions was to invest in battery-powered dermatomes to acquire the grafts, and just like having other considerations. A second was methods for long-term storage. So a lot of places store the skin at -70 degrees, but they came up with a way of storing the skin at 4 degrees in a refrigerator, which is a little more of an easy access than getting liquid nitrogen for -70 degrees. One important note with it was that really these skin grafts were only tested for pathogenic potential. So there wasn't really much concern for immunogenic potential, just because a lot of these procedures were for immediate life-saving and they kind of anticipated a rejection of the skin. And so really they were just focused on testing for pathogens. And then the third unique consideration was the cost of ongoing operations. So one of the decisions was to invest in these high quality foreign imported dermatomes instead of getting something local. And they had cited previous history of getting high quality dermatomes and then having everything else possible basically be local. And that was just a concern because sometimes dermatomes, I guess the quality can vary locally. And so it's sort of a case of spending the money up front to get the high quality dermatomes, and then you don't really have to worry about it failing later. And then the second method was about developing the quality assurance program. And this was adapting the US model to Nepal. And there's a few interesting differences for Nepal, specifically a tradition of having at-home patient deaths instead of in the US where a lot of it's in the hospital, and then also having paper-only records, and then some poor transportation infrastructure. And so they adapted the quality assurance program from the US, and they took a few steps to remove any prohibitively expensive steps or anything that was impractical. And some of that came from running full-scale mock exercises with the full staff, and then just seeing what didn't work or where any problems were. And then they also identified a few key personnel. For example, the skin bank manager spent 4 weeks in India actually at 2 different skin banks, just learning how that operated. And then there's a few specific house staff that were taught to procure donor skin. And then all staff were taught how to store and use the grafts. And the third method was creating the donor awareness. So they made the point that really a skin bank is kind of useless without the skin, and you don't get the skin without awareness and education of the patient population. And so for Nepal, the unique considerations include little concept of organ donation. Really, the only other one that was noted was in 1994, there was establishment of the Nepal Eye Bank for cornea donations. And really, that was like the only other exposure with organ donation. There's also some possible conflicts with religious principles. For example, some concerns with the physical wholeness after death of Hindu patients, for example. And so one of the solutions for that was just emphasizing the life-saving potential of a skin donation, and you can still maintain traditional funeral rites. So it's kind of working to be complementary with local religious principles. And then another consideration was physician education. They were noticing that a lot of rural hospitals I mean, some of it's resources, but basically they'd only be able to do a wound dressing and then transfer the burn patients to the urban hospitals. And so the education was focused on classes for local physicians on 3 sort of basic interventions. That way they could actually triage burn patients and sort of relieve some of the burden on the urban hospitals, and then take care of problems locally if possible. And so the results are pretty interesting. Financially, the article noted that the startup cost for equipment would be about $18,000 and about $120 per donation. And so the estimated cost for the first year of the hospital program was $35,000, and then about $10,000 to $15,000 per year after that. And there's an interesting comparison where apparently a US ICU bed without mechanical ventilation costs about $4,500 per day. So it's a very interesting use of money comparison. And then for patient results, 200 people ended up registering as future donors. So during the first year, though, there weren't any actual donations, and they cited a lack of public awareness. But going into the second year, they were actually able to treat 6 patients with allografts, and those patients had an average total body surface area burn of 40%. And this was actually the first time that patients with a TBSA of 40% were successfully treated with skin grafts and survived in Nepal, which is pretty amazing. And so overall, there was a few notes about post-op. So by 7 days, all 6 patients were showing good take, but then around the 10-day mark, 2 patients were requiring debridement and new allograft for rejected areas. And then post-op day 30, 2 patients demonstrated persistent allograft. And so in total, 2 patients ended up dying after the graft rejection and subsequent sepsis. And then also it was noted that there was 4 out of 6 patients getting a superficial skin infection, although that was in line with the unit's baseline infection rate. And so in conclusion, they did prove that it was feasible to create a skin bank in a low-income country that had no history of allograft skin use. And like I had just mentioned, Nepal registered 200 donors in the first 2 years and ended up saving 4 out of 6 patients with greater than 20% total body surface area, including the first successful treatment of a patient with 40% total body surface area. And then some of the other points include needing to get the buy-in of donors' families and community members. They make a note that in some high-income countries, patients often expire in the hospital setting and also have patient autonomy, basically the patient's wishes being respected. And in some countries like Nepal, it's a little different where many patients traditionally expire at home and also transfer their decision-making or their autonomy to family members. And so it's really important to work with the family and local community members and religious members to talk about the benefits of skin donation and make sure they're on board with giving donations if that's what they want to do. And then also there's a point in tying novel programs such as this to existing ones. So I mentioned in 1994 there was the first cornea bank, and so a lot of folks that opted to donate to the cornea bank were also given education about hey, there's also a new skin bank if you want to double donate. And then and also promoting the successful patients. So there was a 4 out of 6 successful skin graft patients. And so kind of talking them up or having them talk about their experiences to the community. And so, yeah, really that was the whole article. Very interesting and really cool to see the success of, especially with the 40% TBSA patient, which had never been done before.
Thank you, Skylar. That was a great overview of our second reading. Chao, is there anything specific you would like to emphasize or highlight from the reading for the last little bit?
Yeah, sure. First, I just wanted to thank Shaan and Skylar for those excellent, thorough summaries of the articles. I really appreciate that. I think it was great because, we started with a pretty broad overview of just global plastic surgery and what it can be, and then kind of then really dove into the nitty-gritty of one very specific example. So I guess starting with the first article that Shaan presented, I think that when thinking about plastic surgery and global health, I think that plastic surgeons have been some of the first to do quote global surgery, given how long the history of cleft lip and palate missions have existed. I think Operation Smile was founded in the early 1980s, if I'm not mistaken. Whereas, the term global surgery, wasn't really even coined until maybe a decade or so ago. So we collectively, as a surgical specialty, I think have a lot to contribute, given that we have had experience from, the past 40 plus years, doing surgery, in LMICs and doing global health. But I do think that it's important to note that there's a lot of experience, but I do think that there are also lessons learned and mistakes that we've made lessons that we should learn from the mistakes that we've made in the past 40 years or so. And I think that that is something that the article highlighted towards the end that Shaan mentioned as well. And that's really thinking about how to not only just deliver care, but thinking about actually building capacity. So kind of reiterating on some of our themes from earlier. And, one way to conceptualize this is thinking about vertical development versus diagonal development versus horizontal development. And there are articles written about that. I'm sure a lot of you guys are familiar kind of with that framework and that terminology. But I think cleft lip and palate care is a great example of that, where, when we started doing these, it was only a mission model. But, after decades of doing these missions, there were still, I think maybe 4 million, I think was the number that Shaan quoted, patients who were needing this care. So missions and direct patient care and surgical delivery is not going to be enough. And in the past, the past decade or so, it's really been great to see that the cleft lip and palate kind of realm have transitioned to a more diagonal development focused approach, where they are not only thinking about delivering care, but really thinking about how to do it in a sustainable way, where you're integrating the care that you're delivering into the local systems, local health systems that exist. And I think that that's a really important lesson for us to learn in kind of all other arenas of plastic surgery and surgery broadly. And I think the other thing that maybe I'll say about that article is that there's a misconception, I think, that plastic surgery is, kind of too expensive, too complex, too difficult, to whatever, fill in the blank to introduce to LMICs. I think that currently we're seeing that a little bit with microsurgery. When we talk about microsurgery and bringing microsurgery to LMICs, I think there are a lot of haters out there who say, they don't have the capacity either from an equipment or a healthcare kind of manpower standpoint, or it's way too advanced. A lot of arguments against trying to introduce microsurgery. But I can tell you from first-hand experience that in Kirtipur at this hospital in Nepal, they have a microscope and they do more reflux than we do at Johns Hopkins in a week, and their outcomes are excellent. And in Uganda, they also have surgeons there who do microsurgery, and they have challenges with keeping their microscope running, but when the microscope is functioning, they do a high volume of microsurgery cases and have good outcomes as well. So I think that the point there is, don't let the haters get to you. And I guess to transition quickly to the second paper. I think that this paper, I think the most important takeaway is the importance of multidisciplinary and multilateral partnerships in the success of any global surgery project. So this was successful because we had the partnership of academia, so Stanford, and this class that I mentioned earlier. We had industry, so I don't think it was mentioned in the paper, but we partnered with Allosource, which is one of the largest kind of tissue distributors / banking leading companies in the US, and they're actually, industry is really who gave us all of their protocols, and we adapted their protocols for an LMIC setting, because us as a team, we didn't know the first thing about how to, how to treat and store cadaveric skin. We also had NGO, research, like we talked about earlier, and also local partners. And I think that the local partners is, I think all of these partners are super important, and we wouldn't have been able to accomplish what we did if we didn't have any one of these partners. But I really think that local partnership and buy-in from your local partners is super important, because after our project ended, we left, and if there wasn't buy-in, the skin bank would be non-existent, and all of the work that we would have put in and all of the financial resources that we would have sunk into the project would have been totally wasted. But because our local partners also cared about this project, because they also knew about the importance and understood the importance of having cadaveric skin to treat their patients, and because they really believe in the importance of this, they, even after we finished the project, they were able to kind of carry it forward. And so I think that partnership is truly the bedrock and foundation of any global surgery project that you can do, especially if it's surrounding building capacity. Okay, so I think I'm gonna stop there. Oh, we're over time already, so I'll definitely stop there.
Thanks so much for sharing those thoughts with us, Chao. Really appreciate it. So we're running short on time, so we can take a few quick questions before wrapping up, if there are any.
Hi, it's not necessarily a question. I just wanted to, I popped it in the chat, but I loved the focus that Shaan mentioned in the first article about the shift between surgical missions and more upsourcing systems that are already in place, especially with recent efforts. And as Dr. Azad mentioned, a lot of recent efforts in surgical missions have been kind of partnering with the local hospitals and local systems in place. So thank you so much for highlighting that.
Yeah, absolutely. Thank you for re-emphasizing that, because it's so important. Agree.
Hi. Sorry, I think somebody else had their hand up for me, so please go ahead and ask the question.
I just wanted to ask, did you, while building these capacity, did you have issues with the political climate in these countries? And if so, how did you guys manage those issues?
Yeah, absolutely. So obviously that's going to be a very country dependent question. I think that the first thing before you even decide to do a project in a country, I think, is really to assess the political stability of that country, and to assess whether you think that you will be able to successfully complete your project in the given kind of all the political context of that country. So I think that because of that, I would say that when I or the mentors that I was working with really were choosing which countries to work with, I think that that was almost a key criteria, that if there was not political stability, that we were less likely to be working in that country. So in Nepal, politically, we didn't have any issues, although, for the skin bank, though, we did have some cultural issues around acceptability of organ donation in general. And that was a huge problem that we ran into and still are running into. And it's the reason why our donation rates are super low. And I would say that that was a huge unforeseen problem that we came up against. So I think that it's a great question. And I think that it's super important to think about. I luckily, because I think of the kind of the insights and the brilliance of the mentors that I was working with, did not have personal experiences where the country that we were in had political issues that prevented us from doing our work.
Thank you so much.
Yeah.
Hi. So I wanted to ask a little bit about funding. Now, obviously, you've chatted a little bit about microsurgery and the development of that, and that's obviously quite an advanced technology, and there'll definitely be funding barriers to that. But even stepping down towards looking at your trauma registry development, your skin bank development, as was talked about in one of the articles, you were able to find innovative ways to reduce or I guess increase the temperature requirements to be able to actually store skin. All of these things cost money, and building these programs cost money. And there's not a lot of grant opportunities in LMICs to actually fund this work. And there's many organizations in the US, I'm coming from a trauma surgery background, so a lot of the big trauma surgery programs or societies here don't fund global surgery work. So how do you sort of navigate finding the money to be able to do projects like this? Do you engage at student level and use a lot of I guess there's sort of unpaid labor in that sense, or like how are you navigating the key funding issue to actually build a lot of these programmatic strategies that are able to be sustainable over decades of time?
Yeah, that's the $1 million question, no pun intended. So completely agree with everything that you said. And unfortunately, I don't have a magic answer to offer you. There's not a pot of gold at the end of the rainbow that you haven't found yet. That pot does not exist as far as I know either. So I guess all I can kind of share is where we have found the funding for some of the projects that we've done. I would say that broadly, you just have to be very creative and be willing to kind of come up with piecemeal solutions, because, finding winning one large grant that'll fund the entire project from the get-go is kind of a pipe dream, or maybe not a pipe dream, but at least we haven't had success with that in the past. So I will say, so for the skin bank project, there were multiple sources of funding. So we got funding from Stanford, we got funding from Allosource, so industry. I think that industry perhaps is one of the ones that is maybe a more untapped market. Obviously they have larger funds to begin with, but especially when you partner with an industry partner that is that very much so aligns with the project that you're doing. I think that a lot of them, they kind of want to do some pro bono work. It's good for their PR. So I think partnering with industry is one of the options that is less often thought about. And I think partnering with NGOs as well. So research also helped fund some of our skin bank work. But at the end of the day, I think that unfortunately you do have to get, when I mentioned buy-in from your local partners, I do mean financial buy-in as well, because I think that if they are truly bought in, I think that even though they are clearly financially disadvantaged, I think that oftentimes they can come up with some of the funding to fund a portion of it. And if they're truly bought in and think that what you're doing is actually important, they will find a way to chip in. And I think that them chipping in is sometimes a demonstration of whether they're really bought in or not. So, but obviously the amount that you expect from them is relatively low. And I think that really gets to, if you're trying to create a solution, you really have to make sure that it's cost effective. So for our skin bank, before we even went down the path, and one of the first things that we did was to do, kind of run a financial model and see like crunch the numbers and see what the numbers actually were. Because if the numbers were too high, then we wouldn't have gone down that path. And we actually crunched the numbers for not only a skin bank, but for a lot of other options too. So we considered, we have skin banks in America, so can we just ship the skin from America to Nepal? Would that be cheaper? We looked at skin substitutes. Would introducing skin substitutes be a cheaper option? So we looked at a lot of different options, and the reason why we decided allograft skin at the end was because it was the most cost-effective solution. So, and then for my work in Cameroon with the trauma registry, which maybe is more pertinent to your interests, it was kind of association funding. So kind of from either your general surgery, trauma surgery kind of associations, they have some limited amount of grant funding. But I think that ultimately for that, unfortunately, the registry is no longer existent because of our funding issues. So for a while, my mentor was kind of able to support kind of financing the people on the ground who were collecting the data. But then ultimately, she was no longer able to support that. And the local team, even though it was a relatively, low sum of money that it cost to keep the trauma registry running, because it was primarily money just for paying kind of the local staff to collect the data. They were unable to find the funding for that. So I think I'll say some successes, some failures as well. And I think that unfortunately, in the current climate where there definitely are not enough resources to go around, you just have to be very creative, not only looking within academia, but kind of NGOs, industry funding. Really, we actually got some funding from the Rotary clubs in Nepal as well for the project. So we kind of just got as many people on board to believe and buy into this project as we could. And I think that was how we were able to ultimately fund a sustainable solution.
Really interesting, thank you. Especially from the Rotary Club and from industry. Yeah, surprising answers, but that's actually really informative. So thank you.
Yeah, of course.
Thanks for taking the time to answer those questions, Chao. Time really flew by at tonight's Journal Club. So I'd like to just wrap up our Journal Club by thanking Chao and everyone for their involvement in making today's Journal Club engaging. We had an interesting discussion and learned a lot about global plastic surgery. So thanks everyone for their time, and we look forward to having you join us again at our next Journal Club. I hope you all have a good rest of the night.
Awesome. Thank you so much, Ian, for hosting.
Thank you.
Thanks,
Yeah,
everyone.
thank you, everyone.